right, so welcome to Chapter 10, the tissue's response to injury. So the last couple of weeks, last module rather, we discussed how the body actually gets injured. So we discussed the different loads, the loads that can be applied to different tissues of the body, and then what actually makes the injury occur. So now we're going to go into, after the injury has occurred, how does the body repair itself? So this is going to be a really heavy chapter, especially on the science, because we are going to look at the cellular level of how the body heals itself. So let's go ahead and jump right into it. Let's talk about the the objectives of this module. So we're going to contrast the three phases of the healing process, classify the physiologic events that must take place during each phase of healing, identify those factors that may impede the healing process, discuss treatment techniques for modifying soft tissue healing, including using anti-inflammatory medications, therapeutic modalities, exercise rehabilitation, and platelet-rich plasma injections. Discuss the healing process relative to various soft tissue structures, including cartilage, ligaments, muscle, tendons, and nerve. Describe the healing process as it occurs in bone. Formulate a management plan for treating acute fractures. Define pain and discuss the various types of pain. Understand the neurophysiology of pain. Differentiate among the three mechanisms of pain control. And examine the various techniques for assessing pain. So as you can see, this is going to be a real heavy module. So we're probably going to do 3 to 4 weeks simply on this chapter. So we're going to go a little slow just so we can really hone in on certain key elements of the chapter, just so you can fully grasp it. All right, so let's go ahead and begin. So the healing process. So it's essential for the athletic trainer or just the medical clinician to possess an in-depth understanding of the healing process. The healing process consists of three separate phases. You have the inflammatory response phase, the fibroblastic repair phase, and the maturation remodeling phase. The athletic trainer or clinician should recognize both the sequence and the time frames of these phases of healing and realize that certain physiological events must occur during each of the phases. Anything that an athletic trainer does that interferes with the healing process will likely slow the return to full activity. The healing process must have an opportunity to accomplish what it is supposed to do. At best, the goal of the athletic trainer should be to try to create an environment that is conducive to the healing process. There is little that can be done to speed up the process physiologically, but there are many things that can be done during the rehabilitation phase to impede healing. Although the phases of healing are often discussed as three separate entities, the healing process is a continuum. Phases of the healing process overlap one another and have no definitive beginning or endpoints. So let's go ahead and jump into the actual first phase of the healing process, and that's going to be the inflammatory response phase. So once a tissue is injured, as soon as it becomes injured, the process of healing begins. So the destruction of the tissue produces a direct injury to the cells of the various soft tissues. So the cellular injury results in altered metabolism and the liberation of chemical mediators that initiate the inflammatory response. So this is going to be characterized symptomatically. So what the patient's going to be able to tell you, what they're feeling, and then also what the clinician is seeing. And the cardinal signs you're going to see are redness, swelling, tenderness, pain, increased temperature, and loss of function. So this initial inflammatory response is critical to the entire healing process. If this response does not accomplish what it is supposed to do, or if it does not subside, normal healing just cannot take place. So let's go ahead and talk about the different chemical mediators that are released when a cell becomes injured. Okay, so the events in the inflammatory response are initiated by a series of interactions involving several chemical mediators. Some of these chemical mediators are derived from the invading organism. Some are released by the damaged tissues, while others are generated by several plasma enzyme systems. And still others are just a product of various white blood cells participating in that inflammatory response. Three chemical mediators, histamine, leukotrienes, and prostaglandins, and cytokines are important in limiting the amount of exudate and the swelling and injury. Histamine, released from the injured mast cells, causes vasodilation and increased cell permeability, owing to a swelling of endothelial cells and then separation between the cells. Whereas leukotrienes and prostaglandins are responsible for margination, in which leukocytes, in this terms we're going to use leukocytes as neutrophils and macrophages, adhere along the cell walls. They also increase cell permeability locally, thus affecting the passage of fluid, proteins, and neutrophils through cell walls via diapetes to form exudate in the extravascular spaces. Therefore, vasodilation and active hyperemia are important in the exudate, so the plasma formation, and in supplying neutrophils to the injured area. As swelling continues and the extravascular pressure increases, the vascular flow to and the lymphatic flow from the area are decreased. The amount of swelling that occurs is directly related to the extent of vascular permeability and vessel damage. Cytokines, in particular, chemokines, and interleukins, are the primary regulators of leukocyte traffic and help attract phagocytes to the site of inflammation. Responding to the presence of chemokines, neutrophils, and macrophages migrate to the site of inflammation within a few hours. Neutrophils peak at about 6 hours, and macrophages peak between 12 and 24 hours. So we're going to look at a couple YouTube videos in a second here to kind of just have at least a visual depiction of what all this actually means. But first, let's go ahead and keep on going. So let's talk about, so we just talked about the chemical mediators and how those are being released and kind of what they do. But now let's talk about what happens with the vascular system. So this is going to be the vascular reaction. So the vascular reaction is controlled by chemical mediators and involves vascular spasm, the formation of a platelet plug, blood coagulation, and the growth of fibrous tissues. So all that's going to kind of take place here. The immediate, or that's what the chemical mediators are doing anyways. The immediate vascular response to the tissue damage is going to be vasoconstriction of the vascular walls in the vessels leading away from the site of injury, and it's going to last between 5 and 10 minutes. This vasoconstriction presses the opposing endothelial wall linings together to produce a local anemia that is rapidly replaced by hyperemia of the area due to vasodilation. This increase in blood flow is transitory and gives way to slowing of the flow in the dilated vessels, thus enabling the leukocytes to slow down and adhere to the vascular endothelium. Eventually, there is stagnation and stasis. The initial effusion of blood and plasma lasts between 24 to 36 hours. All right, so let's go ahead and discuss the functions of platelets. So platelets do not normally adhere to the vascular wall. However, injury to a vessel disrupts the endothelium and exposes the collagen fibers. Platelets adhere to collagen fibers to create a sticky matrix on the vascular wall to which additional platelets and leukocytes adhere to, eventually forming a plug. These plugs obstruct local lymphatic fluid drainage and thus localize the injury response. And now with the actual function of the platelets, so the accumulation of the platelets, you're actually going to have a formation of a clot. So the initial event that precipitates clot formation is the conversion of fibrinogen and fibrin. The transformation occurs because of a cascading effect beginning with the release of protein molecule called thromboplastin from the damaged cell. Thromboplastin causes prothrombin to be changed into thrombin, which in turn causes the conversion of fibrinogen into a very sticky fibrin clot that shuts off blood supply to the injured area. Clot formation begins around 12 hours after injury and is complete within 48 hours. As a result of the combination of these factors, the injured area becomes walled off during the inflammatory stages of healing. The leukocytes phagocytize most of the foreign debris, toward the end of the inflammatory phase, setting the stage for the fibroblastic phase. The initial inflammatory response lasts approximately 2 to 4 days after the initial injury. So let's go ahead and talk about chronic inflammation. So a distinction must be made between the acute inflammatory response, as previously described, and chronic inflammation. Chronic inflammation occurs when the acute inflammatory response does not respond sufficiently to eliminate the injuring agent and restore tissue to its normal physiological state. Thus, only low concentrations of the chemical mediators are present. The neutrophils are normally present during the acute inflammation and are replaced by the macrophages, the lymphocytes, and the fibroblasts and the plasma cells. At this low-grade inflammation persists, damage occurs to the connective tissue, resulting in tissue necrosis and fibrosis, prolonging the healing and repair process. Chronic inflammation involves the production of granulation tissue and fibrous connective tissue. These cells accumulate in a highly vascularized and innervated loose connective tissue matrix in the injured area. The specific mechanisms that cause an insufficient acute inflammatory response are unknown, but they appear to be related to situations that involve overuse or overload with cumulative microtrauma to a particular structure. There is no specific time frame in which the acute inflammation transitions to chronic inflammation. It does appear that chronic inflammation is resistant to both physical and pharmacologic treatment. All right, so let's kind of unpackage literally everything we just said, because it was a lot. I'm not gonna lie, it was a lot of huge college level terminology. So let's kind of break it down. Okay, let's break it down. So the inflammation process. If you can least memorize these 6 steps for the inflammation process, you're gonna do just fine. So now the very first step that occurs is an injury to the cell. So as soon as the injury to the cell occurs, or when we're talking about cells, we're talking about tissues, that's when the inflammation process is going to occur. So right after that, the thing that occurs is that chemical mediators are liberated. So liberated, essentially they're released from that injured cell. The main ones we're going to talk about are going to be histamine, leukotrienes, prostaglandins, and cytokines. Okay. Now, after that, you're going to have a vascular reaction. This vascular reaction pretty much means that the vessels in the body or by that injured area are going to vasoconstrict. Then so that the vessels are going to get smaller in diameter. Then they're going to vasodilate. They're going to get bigger. And then the exudate creates stasis. Okay. Then platelets and leukocytes adhere to the vascular wall. Phagocytosis takes place, which is pretty much just engulfing all the bad things in the area. And then a clot forms and stops the bleeding so the healing process can continue. So that's going to be the clot formation. So that's the inflammatory response sequence in just 6 steps, 6 easy steps. Now, if you want to know, so when we're talking about formation of a clot, we were talking about fibrinogen, fibrin, a bunch of different things. If you simply understand pretty much the steps of all right, this one leads to this one leads to this. When we're talking about blood coagulation, you're going to start with thromboplastin, then it goes to prothrombin, and then thrombin, then fibrinogen, and then the insoluble fibrin clot. Okay. So when we're talking about coagulations, we're talking about stopping bleeding. So that's when platelets get all together, and it's going to be the formation of this clot. So those are 2 big concepts that you'll need to know for the test. So don't get bogged down by what the entire textbooks is saying and how much information there is. At this point, at this junction, if you can just remember those 6 steps of the inflammatory response sequence, coupled with the 5 steps of the blood coagulation, you're doing good. You're doing just perfect. Okay, so now that's the inflammatory response. So let's keep going. Let's do a quick overview of the fibroblastic repair phase. So that's going to be the next phase. And when I say overview, I mean we're going to go in depth and talk about everything. So I'm going to get through the at least uh, the phase of healing, and then we're going to go more in depth. Okay, so the fibroblastic or blastic repair phase. During the repair phase of healing, proliferative and regenerative activity leading to scar formation and repair of the injured tissue follows the vascular and exudative phenomena of inflammation. All right, so the period of scar formation, referred to as fibroplasia, begins when the first few days after the injury and may last for as long as 4 to 6 weeks. During this period, many of the signs and symptoms associated with the inflammatory response subside. The patient may still indicate some tenderness to the touch and will usually complain of pain when particular movements stress the injured structure. As scar formation progresses, complaints of tenderness or pain gradually disappear. During the phase, the growth of endothelial capillary buds into the wounds is stimulated by a lack of oxygen, after which the wound is capable of healing aerobically. Along with the increased oxygen delivery comes an increase in blood flow, which delivers nutrients essential for tissue regeneration in the area. The formation of a delicate connective tissue called granulation tissue occurs with the breakdown of the fibrin clot. Granulation tissue consists of fibroblasts, collagen, and capillaries. It appears as a reddish granular mass of connective tissue that fills in the gaps during the healing process. As the capillaries continue to grow into the area, fibroblasts accumulate at the wound site, arranging themselves parallel to the capillaries. Fibroblastic cells begin to synthesize an extracellular matrix that contains protein fibers of collagen and elastin, a ground substance that consists of non-fibrous proteins called proteoglycans and glycosaminoglycans, and fluid. On about the 6th or 7th day, fibroblasts also begin producing collagen fibers that are deposited in a random fashion throughout the forming scar. There are at least 16 types of collagen, but 80-90% of the collagen in the body consists of type 1, 2, or 3. Type 1 collagen is found in the skin, the fascia, tendon, bone, ligaments, cartilage, and intestinal tissues. Type 2 can be found in the hyaline cartilage and vertebral disc, and type 3 is found in skin, smooth muscle, nerves, and blood vessels. Type 3 collagen has less tensile strength than does type 1, and tends to be found more in fibroblastic repair phase. As the collagen continued to proliferate, the tensile strength of the wound rapidly increased in proportion to the rate of collagen synthesis. As the tensile strength increases, the number of fibroblasts diminishes to signal the beginning of the maturation phase. The normal sequence of events in the repair phase leads to the formation of minimal scar tissue. Occasionally, a persistent inflammatory response and continued release of inflammatory products promotes extended fibroplasia and excessive fibrogenesis that can lead to irreversible tissue damage. Fibrosis can occur in synovial structures, as with adhesive capsulitis in the shoulder, in extracurricular tissues such as tendons and ligaments, in bursa, or in muscle. So yeah, so a whole lot that I just said. Okay, a couple things. In this phase, if you can know at least what the 3 types of collagen fibers are, more so where they're located, maybe some characteristics about them, then you'll be pretty much fine. Again, I'll try to break it down a little bit easier. I'll try to find a better YouTube video so we can, again, visually depict what's going on. But yeah, I would just say, just at least know the type 1, 2, and 3, and then I'll let you know what else I would like to know for. Okay, let's go ahead and move on to the last phase of the healing process, and that's going to be the maturation remodeling phase. The maturation remodeling phase of healing is a long-term process. This phase features a realignment or remodeling of the collagen fibers that make up scar tissues according to the tensile forces to which that scar is subjected. It involves a decrease in type 3 collagen fibers and an increase in type 1 fibers. Ongoing breakdown and synthesis of collagen occur within a steady increase in the tensile strength of the scar matrix, as well as a decrease in capillaries in that scar, which with increased stress and strain, the collagen fibers realign in a position of maximum efficiency parallel to the lines of tension. The tissue gradually assumes normal appearance and function. Although a scar is rarely as strong as the normal uninjured tissue, usually by the end of the approximately 3 weeks, a firm, strong, contracted, non-vascular scar exists. The maturation phase of healing may require several years to be complete. So as you guys know, if there is any type of damage to your outer skin, especially if it's significant enough, one of the last things that's going to occur is scar tissue is going to form, and that's going to essentially tie in the ends of your skin to pretty much seal off just create a new layer of protection from the injury site, from the innards. Depending on how deep the scar or deep the wound is or how wide it is, the scar might stay there, or the skin might actually overtake the scar, so you don't even notice that you were actually injured. So let's go ahead and talk about the role of progressive controlled mobility during the healing process. So again, this is more going to be talking about the rehabilitative process of what should you have your patient do during this phase of healing. So Wolff's Law states that bone and soft tissue will respond to physical demands placed on them, causing them to remodel and realign along the tensile force. Therefore, it is critical that injured structures be exposed to progressively increased loads throughout the rehabilitative process. So this is where we're going to actually start getting into the theories that you need to start utilizing that injured area almost immediately, or at least almost immediately after the initial phases of healing. So let your body heal for a little bit and then start utilizing it because your body's going to start healing in the way it should, as we're seeing here with how the body's going to align itself based on the loads that are being applied to it. So controlled mobilization is superior to immobilization of scar formation, revascularization, muscle regeneration, and reorientation of muscle fibers and tensile properties in animal models. However, a brief period of immobilization of the injured tissues during the inflammatory response phase is recommended and will likely facilitate the process of healing by controlling inflammation, thus reducing clinical symptoms. As healing progresses, to the repair phase, controlled activity directed towards return to normal flexibility and strength should be combined with protective support or bracing. Generally, clinical signs and symptoms disappear at the end of this phase. As the remodeling phase begins, aggressive active range of motion and strengthening exercises should be incorporated to facilitate tissue remodeling and realignment. To a great extent, pain dictates the rate of progression. With initial injury, pain is intense and tends to decrease and eventually subside altogether as healing progresses. Any exacerbation of pain, swelling, or clinical symptoms during or after a particular exercise or activity indicates that the load is too great for the level of tissue repair or remodeling. The athletic trainer or clinician must be aware of the time required for the healing process and realize that being overly aggressive can interfere with the process. All right, so we literally just covered, like really fast, the entire tissue's response to injury. But as you can tell, it's so much information. Again, this is going to be a college level kind of textbook, so all these things you should have had some type of exposure to in one of your other science classes of chemistry, biology, microbiology, anatomy, and physiology. So if this is the first time you're actually seeing these words and this process, it's going to be a lot to take in. So don't stress about that at all, because we're going to spend the next 3 to 4 weeks kind of diving into each of these phases individually. I really just wanted to kind of just throw out all this information to you just to like kind of shock you, like, wow, this is a lot of stuff to kind of take in. But now, going forward, we're going to literally go through each phase and break it down step by step, what's happening, and really get our hands into this process. Because after that, I want to start talking about how does the rehabilitation process, how's the athletic trainer or the sports medicine clinician, how can we impact this healing process negatively or positively? Okay, so as of now, I'm going to stop right there. So again, you just had a crash course in everything.